I'm enthusiastic today to talk to you about the rationale for treatment. In another episode, I described the rationale for treatment, but this is intended to be more clinical. We will look at the rationale for treatment in terms of the 6 steps that comprise start to finish endodontics, and you can read them just below the rationale for treatment. But if we actually do these 6 steps, from diagnosis to access to glide path management, shaping canals, disinfecting and filling root canal systems, then if we do those steps properly, you can look at some clinical cases to see how it all comes together in kind of an exciting way. Let's get started. First, I would like to look at maxillary teeth anatomy, and then we'll look at how the various steps were performed to get the results that I'm going to show you. Well, if you look at the image on the left, you can see it's a micro CT tooth, and it was done by a great friend of mine, Frank Paquet, from the University of Zurich. Frank is a scholarly person who's a very excellent clinician as well, and he extracted teeth, and through a long, exhaustive process, he is able to exquisitely show us the internal anatomy of the teeth. And we can learn a lot from these scans as teachers and as serious students of endodontics, because it can better prepare us for the task at hand, like the case on the right. Notice this preoperative film. It's an anterior bridge abutment, and it's been previously treated endodontically. Notice that there's a silver point in the canal, and you can see that there is a large diffuse mesiolateral root lesion. There was a perilous, and there's a sinus tract that could be traced with a gutta-percha cone, and it does trace, in fact, to this lesion of endodontic origin. This is a classic example of a previously treated tooth where the previous obturation material is overextended vertically, but the root canal system is internally underfilled. Overextended and underfilled. So what we need to do is make a careful access back into the clinical crown, recognizing it is a bridge abutment. And then we need to be thinking about extricating that silver point from the radicular space so that we can reclean, reshape, and then fill the root canal space. Well, post-operatively, you can see that we have eliminated the silver point. We have a nice dense fill, and you can see then that there's some surplus apically, but there are 3 significant and important lateral canals. And notice these feed the lesion of endodontic origin. And the puff is at the portal of exit. So there are 4 portals of exit on this single-rooted tooth. Now, it doesn't matter what we talk about today. If it doesn't work, it's irrelevant. So we need to follow these cases. And here we are looking at this case 20 years later, and you can see how the bone has repaired. You can see how tight the bone is on the lateral aspect of that root, and healing has become complete. So, properly performed, endodontics is the cornerstone of restorative and reconstructive dentistry. So we'll always go back and look at Frank's work to show examples of a very unusual first bicuspid. This is a maxillary first bicuspid. It has a fused root, but notice that there is a middle 1/3 division, and then the more lingual branch divides again more deeper in the apical 1/3, and so we're setting this abutment up for a splint that will double abut on the first bicuspid and the canine. Wouldn't it be nice to have complete endodontics? In this maxillary first bicuspid, you can see that this gutta-percha point is tracing a sinus tract again to a lesion of endodontic origin. Notice the root proximity of the first bicuspid to the floor of the antrum. 20% of all sinusitis is odontogenic in origin. So it really behooves clinicians to roll up your sleeves proverbially and do the vital pulp testing when patients complain of rhinitis, postnasal drip, stuffiness in their nose, or maybe even unilateral suborbital pressure. These are all classic symptoms of sinusitis, and so our jobs as dentists is to rule in or rule out a tooth of odontogenic origin that might be feeding that problem, because it could be allergenicities secondary to sinusitis. So in this particular first bicuspid, There's a large restoration, there's a deep base, and you can again see the rationale for treatment is not only to get the apical lesion, but to get the mesial lateral root lesion as well. And how we get that is with careful access, negotiating the canals, shaping, voluminous amount of irrigation, actively moving that reagent into the deep lateral anatomy where we are unable to instrument. These uninstrumentable portions of the root canal system can be cleaned, but it's through active irrigation. And through active irrigation, we can remove pulp tissue, microbes when present, and this gives us the opportunity to fill root canal systems in 3 dimensions. Notice 20 years later how tight that bone is around the perilateral ligament space of the tooth that we've just treated. Another bicuspid tooth, if you look very carefully, there's a large diffuse distal crestal lesion of endodontic origin. You can begin to see the root is kind of complicated if you're looking for the canals moving all the way to the apical regions, and there doesn't appear to be much of a lesion of endodontic origin associated with the apical 1/3 of this root. When we went into this tooth, I'm skipping to a 10-year recall, you can see the fun of finding the 2 canals. Ruddle knew there were 2 canals present, but if you look very carefully, you can see there's multiple portals of exit. And you can see some opacity within the body of the shaped canal, and that means ramification that's either coming directly at us into the plane of the primary beam of the X-ray or away from the beam. But here we are with complete endodontics and the inevitability of the bone to repair itself following careful procedural flow. Now in this particular tooth, this is a high magnification view through a microscope, and I'm looking up into a cleaned out pulp chamber, and we've left a post space in the buccal branch. If you look in the wall of that canal coronal to the gutta percha, you can see a pink circle in the lateral wall of the shaped canal. If we go to the radiograph, you're going to see it's a rope of gutta percha that's been compacted into that lateral branch. And in fact, if you look at this post-op film, you can see this abutment's going to be tied up in an extensive splint, and isn't it neat to see all the portals of exit sealed? We shouldn't fret what's in the lateral canals. It could be all gutta percha. Certainly, it could be all sealer in the really small ones. Usually, it's a mixture. And you'll have a little gutta percha in part of the ramification, but as we get further away from the heat and the force of condensation, the little plunger of gutta percha will piston sealer on out to the cavo surface. So when we say a mixture, sometimes in these lateral branches you can find a mixture of gutta percha and sealer. Notice the recurvature on the lingual branch in the apical 2 millimeters. Simple endodontics, maxillary first bicuspid, 3 apical portals of exit. You can see the shapes are just clean, simple, but well-shaped canals can hold a reagent, and it's the reagent that cleans root canals out. So I really want to emphasize files shape a canal, but irrigates clean root canal systems. Maxillary bicuspid, this one's carrying a 4-unit bridge. We need to have all those 6 steps that I've continuously identified as comprising start to finish endodontics perfectly managed. And when they're well managed, we can get predictably successful outcomes. Now I know some of you from time to time email me and you express surprise because you're in a maxillary bicuspid that has molar anatomy. And you were surprised because oftentimes the colleagues tell me they initiated treatment with a single preoperative film. I really want to stress and emphasize the importance of moving the X-ray cone up to 30 degrees off axis in the horizontal plane. So you get the straight on view, then move the cone 20, 25, or up to 30 degrees mesial to the straight on view, then go back to the straight on view and move the cone up to 30 degrees distal horizontally from that straight on view, and you will begin to appreciate before you ever talk to your patient about the anatomy. and you can communicate chairside and tell them what you're up to, what needs to be accomplished, and you'll have a fee that's appropriate for the work at hand. Shouldn't this be your molar fee if you're treating a little bicuspid with miniaturized anatomy like a molar? Okay, let's look at molars. And in Frank Pauquet's spinning micro-CT, begin to appreciate the MB root. And then appreciate that in that MB root, clinically, from the research, we know that about 90% of the time, clinically, there's a second system. And if you do the postmortems on extracted maxillary first molars, you'll notice how broad that root is facial-lingual, and it's no surprise to you today that broad roots frequently hold a second canal. But then even look at the aberrations off of those canals in their terminal extents. So this is a challenging tooth. It's probably generated more research than any other tooth in the mouth. It's the largest tooth by volume, and it's so misunderstood, and the most common cause of failure in the maxillary first molar is failure to identify the more lingual second, what is termed MB2 canals. Let's look at some of these canals, and you can see the tooth on the right doesn't have a classic MB2, but you can see a little opacity within the MB canal coronally, and that's a fin where material has been moved into that eccentricity off the rounder part of the shape. But notice in the DB and the palatal systems we have resorption, lateral canals, and apical bifidity. All normal anatomy. And in this maxillary first molar, you can see that there is not a lot of pulp chamber left. The roof is almost approached the floor, and so it speaks to careful access, because we're not going to fall into this pulp chamber. We're going to have to be very careful that we don't blow through the chamber and start working unintentionally on the pulpal floor. But notice the entry angles of these canals as they move into the pulp chamber. Especially begin to appreciate the coronal 3 to 5 millimeters of that MB system and how awkwardly and abruptly the canal turns distally to enter into the pulp chamber. This really speaks about careful access, removing triangles of dentin, etc., etc. Well, the post-op film is pretty exciting. Straight line access is exemplified. You can notice that in this particular instance, the MB1 and 2 did merge and exit as one. So we know that over 90% of all maxillary first molars have two systems. Now let's learn a little bit more about this tooth. We know from Stropko's famous paper that was published in the Journal of Endodontics, looking at thousands of teeth clinically on patients of record, he reported that about 60% of the 90%, the canals did exit as two or more separate apical portals of exit. This means that about 40% of the time, the two canals merge and exit as one. Here's one example, a molar posterior bridge abutment where the MB1 and 2 are separate, and they do exit in two or more separate portals of exit. This is a good sign if we're trying to set this molar up for a long-term result. Now, in another segment, I've talked about the 17 ways to help you identify calcified canals, aberrant canals, or in the retreatment situation, previously missed canals. And in one of those ideas, we talked about the red line test. In a vital case, blood will emanate from space. And if there's pulpal space that houses pulp tissue, then bleeding is normal. And we can use the bleeding as an indicator of where there is space to locate, so we can instrument this area, shape these canals, disinfect them, and fill them. And you can see off the DB, there's a long ribbon that goes way out towards the middle of the pulpal floor. Are you going to have the courage to stick a tin file into the trailer part of this fin? Well, if you did, I'm going to put my arm around you and tell you you did a damn good job, because if we go to the post-op, you can see there was a DB1 and 2, there was an MB1 and 2, and a palatal. So this maxillary first molar actually has 5 treated systems. This case now is a little bit older. I've shown this case internationally around the world. I like to continue to show it because many cases we can show you have 3 systems in the MB root, but this case was perhaps a little bit more remarkable in that there was significant apical recurvatures associated with the MB1, the MB2, and the MB3. Notice the palatal is bifid, and there's a significant lateral canal to a lateral root lesion associated with the distal buccal system. So here we have a maxillary molar. It's carrying a long splint. It's tied up in reconstructive dentistry, and this is the rationale for treatment. We are to remove all the pulp so we can have the best possible chance for a long-term successful result. And here we have a maxillary left first molar. There's a palatal 1 and 2. There's a mesial buccal 1 and 2. Notice the long anastomosing between the MB1 and 2. And then there's a DB1 and 2 again. So this maxillary molar has 6 systems. What's the point? The point is, when we talk about the rationale for treatment, of course, after diagnosis, the most important step then would be the first step, and that's access. And we need complete accesses, and I'm really trying to emphasize today to have aboard the technology that allows you to see well and visualize pulpal floor anatomy. And then finally, in this case, this is a combination of a palatal root resection by the periodontist. Then it was referred to me to do endodontics on the buccal roots only. And then from me, it was referred to the restorative dentist to do splint dentistry. This dentistry isn't done frequently anymore because with the advent of implants, oftentimes when teeth get furcation involvement, they're extracted in favor of implant dentistry. This is a 23-year recall. So notice when each discipline performs its step properly, periodontally, endodontically, and restoratively, you can get these long-term results that can compete absolutely favorably with implants. But the secret was complete endodontics. Ruddle never knew that within the anastomosing between the MB1 and 2, there was another whole system, and it has its own linearity, and the puff is at the end of that portal of exit. So 3 systems, 3 portals of exit associated with the MB root alone. And in the last case, I will just share with you now in closing that 91% of my practice is retreatment. Out of every 1,000 patients I see in any given year, 900 of them arrive and they've already had endodontics like this palatal root. And this was treated, the palatal root was treated by an endodontist in Los Angeles. There are thousands of dollars of dentistry on this inadequate foundation. And our profession needs to realize that things that don't look right aren't right. And deficiencies in primary treatment oftentimes sabotage our potential for success. And when we have our success compromised underneath thousands of dollars of reconstructive dentistry, it's not a happy day for the patient and certainly not for the dental team. So, working with the dental team and following interdisciplinary treatment, we had the reconstructive dentistry take off the splint so Ruddle could retreat the palatal root. The buccal roots were long ago resected, but this pier abutment was deemed critically essential to carry this long 6-unit splint. So there was no discussions about implants other than it was an option, but why not retreat the palatal root? The patients flared up a couple times. They've had to go on antibiotics. There's a thickened periodontal ligament space, but if you were to look at a CBCT scan, there's a frank lesion with sinus communication. One visit to remove the gutta percha and to get through the block, probably an hour and a half to get through the block and get to the apical portal of exit. I only knew during retreatment that there was one apical portal of exit. However, in my postoperative film, when the bridge has been reprovisionalized, I never realized that there was a bifidity deep. I never knew there was a loop to the distal, and I often wondered, was this supracrestolateral canal to the base of the defect, was that why the tooth originally had periodontal resection procedures? In other words, was it a periodontal lesion that was masquerading around as a periodontal lesion when in fact it was actually a lesion of endodontic origin? But in any event, 15 years later, the patient still has the palatal root and the splint is working beautifully. I hope this segment on the rationale for treatment, focusing on clinical cases, gets you excited to see your next patient who needs you to perform complete endodontics.